about the crush. And as you all know, that we have evolved over a period of time with the crush technique, starting from the classical crush, then nano and mini crush, and there is also one DK crush which has got a very robust data behind it, a lot of positive data behind DK crush, one of the standard treatment of choice when it comes to upfront two-stent strategies. So first of all, as you all know, just a brief slide about simple true bifurcation and complex true bifurcation. Complex true bifurcation, classical 1-1-1, and the side branch is quite sizable. It supplies a large myocardium, like for example, the circumflex when it comes to left main bifurcation lesion, or it comes LED diagonal kind of. And based on the definition criteria, if the side branch is more than 90% non-left main or more than 70% in left main, and the lesion length is more than 10 and heavily calcific and broad angles, then it falls into the criteria of complex left main complex bifurcation lesion. And in this case, it is usually thought that upfront two-stent strategy is the treatment of choice in most of the cases, specifically based on the DK Crush 8 and definition trial. So these are the data behind it. The purpose of bringing on this slide is that DK Crush is not just the authority. There are other trials as well based on, for example, if we look at the EBC main trial, in which Q-lot was done in 53% of the cases and TAP 33% of the cases. In Excel analysis, again, TAP was 50% and Q-lot 23%. But when it comes to DK Crush 5 and definition trial, it was the trials which showed superiority of DK Crush compared to other stenting strategy, for example, in the form of either Q-lot or TAP strategy when it comes to definition criteria. So the main purpose is that you should have a grip of any one of these bifurcation strategies, and you do the steps appropriately, and the end results will be good, and the long-term outcome is better. So it's not necessary that we stick on one trial, one procedure. We should get the hold of all the basic steps of the main procedures, like, for example, 1 or 2, and we can follow the techniques then. So if you look at the mini crush, or the crush, or the mini crush, normally it requires a 7 French guide, because we are taking 2 stents simultaneously. When it comes to the DK crush, we crush the stent with a balloon, so it can be done with a 6 French guide. But since we are taking 2 large size stents in a single guide, so it's not possible with 6 French. So this can be considered as one of the drawback of a classical crush technique or a mini crush technique, because we are dependent that we have to take a 7 French guide. And normally when we take a 7 French guide, we go from the femoral route as well. So what happens in this, that first of all, the side branch is deployed, 1-on-1 ratio after obviously lean preparation with 2 millimeter protrusion into the main branch. This is mini crush. In the classical crush, it is 3 to 4 millimeter, which was described about 2 decades back by Colombo, in which the stent was protruded about 3 to 4 millimeter into the main branch, and then it was crushed. However, it has evolved over a period of time, and mini crush requires approximately 2 millimeter protrusion of the side branch stent into the main branch. And it's very important that we keep a stent already in the main branch, and we crush the side branch stent after deployment with this main branch stent. Now, this is the problem over here, which was over a period of time improved by the DK crush method, in which we crush the stent, the side branch stent with a stent in the main branch, and then we have at the carina 3 layers of metal over there. So it's very difficult to recross and do a kissing. And certain studies have shown, well, seen in swing sides, that there was at times in the cactus trial, it was quite difficult, and only 77% of the patients had recross successful and kissing balloon inflation. So that was why this technique of classical crush was evolved over a period of time. So the branch is rewired to the non-distal strut. Then KBI is performed, 1:1 to distal branch, and final plot. So these are the steps of classical crush technique, in which a stent is placed in the main branch, and it crushes the side branch stent. We perform a report, then recross, kissing balloon inflation, and then a report again. So we can also do a crush with a 6 French, but the main thing is that in that case, just like a DK crush, we'll have to take a balloon to crush rather than the stent. And this, after crushing with this balloon, we'll have to take the stent and then recross and do the kiss. But the classical crush that was initially explained about 2 decades back, it was with 7 French guide, and we used to use a stent to crush. Now let's see what's the pitfall. So these are the things. As I said, when the classical crush, we have 4 to 5 millimeter protrusion of the main branch, and then over a period of time we had improvements. In mini crush, we have 2 to 3 millimeter protrusion, And we have now in nano crush as well, in which we have minimal protrusion of 0.5 to 1 millimeter. So what normally we do, we inflate a balloon into the main vessel, and slowly and gradually we pull back the side branch stent, and once it abuts the main stent balloon, we are sure that it has protrusion of 0.5 to 1 millimeter. So this is very tricky one as well, because at times there is chance of missing the side branch ostium if we are doing this technique. So we have to be very careful, take different orthogonal views to make sure that there is only minimal 0.5 to 1 millimeter protrusion. The purpose of this is that then we'll have 2 layers of stents to recross for the side branch rather than for the recross from the main branch, rather than 3 in the case of classical crush. So importance of rewiring: if unable to rewire and do final case, much higher risk of MI and TLR, that's already known. Without kissing balloon inflation, side branch stent is distorted, irregular and expanded at the very ostium. So the importance of kissing balloon inflation is very much over there in literature, because a lot of MACE is associated if we don't kiss a balloon. In any bifurcation stenting study, the final kissing is very important, because if you don't do that, the stent remains distorted at the carina. It is not formed properly, and that is why there is increased risk of MACE over a period of time. Another important thing is that in the Cactus trial, we had inability to rewire in up to 25% of the cases. So 3 layers of stent, very difficult to recross. That is why in approximately a quarter of the patients, they end up without doing a recross in final case. So over a period of time, the procedure was evolved, and then Professor Chen et al. Came with the DK crush technique. So in Cactus trial with classical crush, we were able to do final case caused MI 29 versus 7.5%, TLR 13 versus 6.7%, and stent thrombosis 6.5% versus 0.9%. So in all those cases in which the recross could not be done, final kissing could not be done, there was a lot of MACE involved in this case. So hence DK crush. The main advantage of DK crush over simple crush is ability to rewire and do final kissing in approximately 100% of the cases. Because we now know with the minimal protrusion, we crushed with the balloon, and if the proper crushing is done, rewiring is much easier. So rewire from the non-distal strut, do the first case, open up the struts, deploy the stent, another recross, that it makes the other recross very easy as well, and that is why we have efficiency of 100% in DK crush when it comes to compared to 75% as we just said in classical crush. However, this was also successful, 98% of mini crush and nano crush as well. So if the nano crush is also done properly with minimal protrusion, obviously we'll have to recross 2 layers of stents, and that will be much easier. So this is the theme of today's presentation. What are the basic steps of DK crush, and how to do them properly, and how to avoid any kind of misconception. So the first step is that vessel preparation is side branch stenting. So once we have decided to go with the upfront 2-stent strategy, and when we have decided to have the DK crush as the default technique in that case, the first important thing is to make sure the lesions are prepared properly. So this is the hallmark. Make sure that if there is any calcification, any rotablation that you need to do upfront. Because if you leave it for the later on, stent deposition can be a problem. Rewiring into a calcific vessel can be a problem. So make sure that your main branch and side branch are properly assessed. Ideally with the imaging, if you have that ability, you do imaging and make sure if there is any calcification, plaque modification need to be done with a cutting balloon or with a rotablation, you do it up front rather than deploying stents and doing it later on. So this is the main important step, is to vessel preparation. This is followed by, if you look into the graph, is that we place a balloon and we place a stent into the side branch. The side branch stent is positioned 2 millimeter protrusion and then deployed. So how we size the side branch stent is from the distal vessel diameter of the side branch. So once we have done the IVUS and we see that the distal vessel is approximately from media to media is approximately 3 millimeter or 2.75, whatever. So we size the stent to that. And we take a main balloon, a balloon in the main branch, a semi-compliant balloon, and the size of that balloon should always be sized to distal. For example, if the distal main vessel is 3, so we take a 3O balloon. We place it, we slightly protrude the main branch, the side branch stent into the main branch, approximately 2 millimeter. We see in different views, make sure that there is not much protrusion, and it is deployed. Side branch stent balloon may be slightly withdrawn and then reinflated to high pressure. This is very important because we have to make the stent to be a kind of, you can say, open up at the ostium. So once we have deployed the stent, we pull back the balloon slightly and go to 2 millimeter higher atmosphere, so make sure that it is flared up properly before we do a crush. So, and and then reinflate to higher pressure. The technical tips in this case is that a stent artery ratio of 1.1 to 1 or 1 by 1 by visualization is recommended if the procedure is guided by angiography. So if you're doing angiography, you have a catheter, you know that it is 2 millimeters, so we use that as a benchmark, and when we have to size the vessels, we size it based on that, and its ratio should be 1.1. The ratio should be 1.1 or 1 to 1 by visualization. Before removing the side branch, a non-compliant balloon is usually used to fully expand the side branch. This is optional. As I said, we pull back and go higher. So we can also even use a non-compliant balloon to make sure that this is flared up properly before we crush it. So this is the first step. Vessel preparation and also protrusion of the side branch slightly into the main branch and making sure it is deployed properly. And ostium is flared as well. So step 2 is the crush. So the balloon, initial balloon is this one. And we crush by 1 to 1 to distal main vessel. This crush the protruding section of the side branch. Further prod crush will be proximal sizing as well. So in this case, it's very important to make sure that it is a two-way crush. Initially, it was thought that one crush is enough with the main branch that is already there, but now there is sequential crushing. This is the main modification in the recent past. And if you look at this slide, this is the importance of the sequential crush. Normally we do, first of all, the balloon in the main branch, which is sized to distal, 1:1, for example, the vessel is 3, so we take 3 balloon, and we crush. If you crush like this, the distal gun, the stand will be placed like this, and it's not total crush. This is the access into the main vessel, and this is the access. Just imagine if this vessel is crushed like this, the side branch stand, and we try to recross, the wire can go anywhere. It can go into this. It can go through the struts. It can go even between these two struts into the stand. So the side branch wiring will be very difficult if there is improper crush. So that is why we take another balloon, which is balloon crush, which will be sized to the proximal reference diameter. This is the same balloon which we'll be taking for pot later on. So, for example, if the main vessel is 3.5 or 4, so we take a 4 balloon and we do another crush. So this is two-step method. One is the main balloon which was already in there, sized to distal, we do the first crush. We remove this balloon, we take another balloon which will be sized to the proximal vessel, and we do another sequential crush. So this is the result. You can see the struts are quite open in this kind, and you look at this one, it is now properly crushed. So this sequential crushing is very important. And it has come up to the literature quite recently, and it has shown that this is very important for not only rewiring, but also for proper crushing of the stand. So this is the second step, which is the crush. And again, I reiterate, the sequential crushing is very important to make sure that the stand side branch is crushed properly, and this will help in the rewiring and the first casing balloon inflation. So we go to the next step, is the rewiring. Start. So this is very important when it comes to the crush. Any classic crush, nano crush, rewiring from the non-distal crush or proximal crush is of paramount importance. This, in the next slide, I will show why is it important. But it's important that we rewire. In all other crush, in all other bifurcation strategy, we can cross from the distal strut. But when it comes to DK crush, it has to be. A lot of people should not be obsessed if it is not crossing. Make sure that it recrosses, but it's very important. For proper DK crush, it's very important for you to recross from the non-distal strut. It's very important. And that is why it's important for you, if you have the IVUS at bay, if I'm doing the IVUS anyway, you make sure using an IVUS, the longitudinal section, it will help you in ascertaining that the wire is recrossed from the non-distal strut. So this is the wire. You've done the pullback, and you have notified that this is the wire, and you see the longitudinal section over here, and you can see the lumen over here. So this is distal, this is proximal, this is the side branch, this is, you can see these two struts, this is another strut, and your wire is crossing from the non-distal, that is the proximal strut. So make sure, it's not just this, if you have the IVUS, you can make sure. If you don't have the IVUS, you can use the stent boost techniques, which is present in a lot of cath labs. You can take the orthogonal views, you can do a double magnification, but it's very important for you to make sure that your wire is recrossing from the proximal or at max non-distal struts. So this is very important. The third branch is to recross. So this is why it is important to recross from the proximal strut. For example, if the wire recrosses from the distal strut from over here, it can go under the stent like this into this, and if we expand this, it can further crush the stent and makes a lot of problems for you. So that is why it is important for you to cross from the non-distal or from here, so that the stent is opened up properly rather than going from over here. And this will. Another problem is that it will leave this area without any strut. This new carina that will be formed, it won't be having any struts, which can increase the maze further on. So that is why it's important to recross. A lot of people ask about the shape of the wire when we are trying to recross. It's a lot of things depends upon the operator, how he's comfortable. But normally they say the length corresponds to the length of this corresponds to the diameter of the proximal vessel. So we shape it like two bends we are given, primary bend and the secondary bend. So this bend, the shape of this length is based upon the length of this main pressure wire. And the sharpness, the angle depends upon the angle of the takeoff. So the more acute angle, the more acute this bend is, and the more obtuse or the more right angle, so the more angle we will give it to this branch. So that is how you shape it. So this is very important. The first step was the sequential crush. Obviously after lean preparation, sequential crush was the first important step. The second step, very important, is to recross from the non-distal, ideally from the proximal strut. Now we come to the casing. How we size the balloon when it comes to the first case. So balloon size 1:1 to distal main vessel. Now we can take the non-compliant balloons. The basic theme is that a lot of people ask about which balloon to take, semi-compliant, non-compliant. When you are ballooning within a stent, it's ideal to take a non-compliant balloon. And if you're ballooning with a vessel, normally you take a semi-compliant balloon. However, in this case, since this balloon is going to this stent, so we take a non-compliant. And this is optional. You can take non-compliant or semi-compliant balloon in the main vessel. So balloon size 1:1 to distal. For example, if this is a 2.75 vessel, you take a 2.75 balloon. And if this is a 3O vessel, you take a distal vessel diameter is 3O, you take a 3O balloon. And sequential high pressure inflation followed by simultaneously low pressure inflation is important. It's very important. A lot of people ask about what are the pressures. So normally what we do, we first of all post-dilate the side branch first to approximately 14 to 16 atmosphere, which is the normal routine. Then we deflate the side branch balloon. We inflate the main branch balloon to approximately 16 to 12. And then about 1 to 2 millimeter protrusion to the main branch, like over here. We do simultaneous cleansing at 12 atmosphere, 10 to 12. Not to maximum, because we have two balloons in the main branch. If you go 16, then we can have problem with the main branch, we can cause perforation. So sequential balloon is important in a way so as to avoid any complication into the main branch. So what are the technical tips? In cases where the non-compliant balloon cannot be easily advanced into the side branch, critically assess the accuracy of the rewiring position. That's very important. A lot of people normally what they do, for example, if the wire is into the side branch, and if your main wire balloon is not going, for example, you are taking a 275 NC balloon and it's not going to the side branch. A lot of people think that, well, we can take a 1.5 balloon, then slowly go up. Normally, it is not recommended. You make sure that your wire gone properly, because if your balloon is not going, and if you had already crushed it properly, it should go. If it's not going, then first of all, reassess the side branch wiring, whether it is gone through the non-proximal strut or not. Because if it has gone from, like over in this case, if it is, sorry. For example, if it has gone from here, so that is why the balloon will have difficulty in crossing, because there will be already crushed stunts, your wire will be already abdominal. So if your 2.75 balloon is over here, it should slip easily. If the wire is gone from here, you will have difficulty. The problem is that what we normally do, if the balloon is not going, we take a 1.5. So if the 1.5 will open as this strut further and will cause further deformation of the side branch stand. So make sure if the balloon is not going, that your wire position is in the side branch is proper or not. The other technical is that two non-compliant balloons should have a short, usually 2 millimeter overlapping in the main branch. So the overlapping in the main branch is very important. It should be long enough. It should be just a short one to make sure, because maximum pressure will be applied on the ostium of the side branch and also in the main branch. So that is why, because if we go further back, the pressure distribution in the ostium of the side branch stent won't be appropriate. So that is why we should be as close to the side branch with minimal 2 millimeter balloon. So this is the first KBI. A lot of people ask, why do we do a first KBI? It is very important because of different reasons. The first reason is that, for example, look at this. If you don't do the first case, we will have only limited space over here. Look at this, for the access of the main branch stand. And our wires and balloons can go anywhere over here. So that is why the first case is important, so as to make sure this conformation is appropriate. The main branch is very much, we have appropriate space into this. Another problem with not performing the first case is an excessive metal, just like the classical crush. There will be excessive metal over the side branch ostium 3 layers. And again, it will be difficult to recross. So that is why Professor Chen came up with this strategy of the first case to make sure that we have appropriate space on the side branch as well, appropriate space in the main branch for delivery of the stent and balloons, and we have easy access into the side branch later on as well for the second recross, and we avoid multiple layer of stents over here. Now the next step is main branch stenting after withdrawing kissing balloons and side branch wire. So a lot of people think that this is optional of removing the side branch wire, but normally they say that it's better that we remove the side branch wire. The purpose is that people say there is risk of losing the side branch and it will act as a marker for example, to recross. But if you have performed the first case properly, there's very less or negligible chances for losing the side branch. So that is why it's important that we remove the side branch wire and the kissing balloon. Now what we do, we deploy the main branch stent size to distal. For example, if the size is 3.0 or 3.5, we put a 3.5 stent and deploy it. What are the technical steps? The main branch stent is also sized using distal main vessel diameter. That's very important. Operators should aware be the expandile limits of different stents. As an example, a 3 millimeter synergy stent cannot be dilated up to 4.5. This is very important when you're doing a left main bifurcation stenting because there is a mismatch between the left main and the LED and the circumflex. So make sure if you're coming to the left main, we take a stent which can be expanded to a particular limit. For example, if you're taking a synergy stent and the left main is 4.5 or 5, I mean, it cannot be dilated to that level. So you should have that knowledge in mind that what kind of stent you are taking and what are the expensile limits of each of the stents. So this step is important that we deployed the stent. Now port is very important. What is the importance of port? We all know. For example, if you don't do the port, our recrossing will be difficult because it has every possibility of going under the struts of the main branch. So once we have deployed the main branch stent, we take a port balloon. This is the exact location of the port balloon. It should be at the distal vessel edge of the side branch. You have to go and cover the carina over like this. It has got importance because it will open up the struts further and will also make the second recross much easier because the stent will be now expanded at the side branch. And the size of the balloon is based on the proximal vessel diameter. For example, if it is a 4.0, so we take a 4.0 balloon and we port. We will be having this balloon anyway in our, because we would have done the sequential crushing with this balloon. So that is why this balloon will be over there. So it will be sized to the proximal vessel diameter. And we now do a port. This port is very important, not only for proper apposition of the main branch vessel, but also for access for further rewiring and further balloon delivery into the side branch later on as well. This has to be non-compliant. Yeah. Even in sequential crushing, you can take a non-compliant balloon. So make sure, if, for example, to make UFCAN 1 limit. But ideally, it should be semi-compliant. You should have enough inventory with you. But if there's some problem with that, you can take a semi-compliant. Yes, exactly. So final KBI, again, final KBI should be from the non-distal strut. And again, it is very important to make sure that you have recross from the non-distal strut. Again, IVUS can help in the form of this. You can see again, this is 1, 2, 3. This is the distal struts. This is the main strut. And again, your wire has gone from the proximal strut. So very important. Again, you can use a stent boost techniques, different angulations, and make sure that the rewiring is proper. So use short balloons, size 1:1 to the distal main vessel in the side branch, and again, sequential. Alternate inflation at 16 atmospheres starting from the side branch to the main branch is crucial to ensure there is no gap between the stent struts and carina, and maximal expansion of the polygonal confluence is important. So this final KBI is very important, and you do make sure that there is sequential crushing so that the side branch ostium is properly opened up the main branch vessel is also opened up, and then you do a sequential crushing at approximately 12 atmosphere, and that is again very important because it will make the confluence now properly shaped as well. So this is the final pot. Now that we have done the kissing and we have made the confluence very appropriate now we have to position this balloon in a way that it doesn't go over here. Otherwise, it will make all your hard work go haywire if you put up the balloon till here. So it's very important that we only use an appropriate size balloon over here. Again, looking at the inventory is very important. If you have protruded approximately 4 to 5 mm to the main branch, make sure you have that appropriate size balloon and the inventory as well. End of the day, if you have a large big vessel balloon, then you will be struggling because, for example, you don't have a, for example, 4/8 balloon and you have protruded approximately 8 mm into the main branch, and you have the smallest balloon is 412, then obviously you have chances of causing dissections because that balloon won't be appropriate. So before you start this, it's very important to make sure that you have appropriate size balloon present over there as well. So use a slightly more proximal balloon position to avoid the neocarina. This is very important because now you have made the confluence very methodically by doing non-distal recrossing, taking appropriate size balloons, taking sequential kissing and all that to make sure that your hard work doesn't go waste. This positioning is very important. So you should avoid the neocarina over here. Okay? To sum up, so these were the steps. You have any question, any query based on all these steps? It's coming in your mind. Any question? So for operators with appropriate experience, DK crush is a valuable option for complex bifurcation lesions based on the definition criteria. So DK crush, knowing the basic steps and performing it properly has a lot of importance because it has got a very robust data behind it. If you can see the DK crush trials starting from 1 till 8, the definition trials all have shown the superiority of DK crush, not only against the provisional strategy, but against other two-stent strategies as well, like Q-lot or TAP for that matter. Key contemporary steps that make a successful DK crush are just performing DK crush is not enough. You have to perform a successful DK crush. And how we define a successful DK crush? By following each and every step very methodically. And what are the various steps? Number one is side branch optimization. The stent that is flared up properly. So we can take another NC balloon or the same balloon to atmosphere up by slightly pulling it up. The second step is the sequential crush is very important. And I showed the reason behind this with the image as well, that the strut, which is not properly crushed, there's all the problems arising with it. The proximal side branch recrossing is paramount importance. In both the cases, the two recross that you do, first for both the cases, first and the second case, it's very important that you do. And you recheck using different methods like IVUS, imaging is the gold standard. If you don't have the imaging, you take the different stent boost techniques, you can different angulations to make sure that your wire has passed from the non-distal strut. Repeat pot after main branch deployment after kissing burst. So if you properly do these 3-4 steps and your stents are probably then you can be sure enough that you will have long-term outcomes in terms of low mace by doing this step. Intracoronary imaging strongly recommended for optimal procedure results in complex regions. So thank you very much. Any query, question? So we have a couple of cases, DK crush and mini crush both. Dr. Khurshid will show you the steps of DK crush. Then I have a case of mini crush. If enough time, I can show you that as well.